Here we have an interesting case of a female 12 years old. She has recurrent chest infection since early childhood. Available scans is here 2021 and 2023. According to the findings that we can see here in 21, we have predominant upper lobar bronchiectasis and mucus plugging and tree embed. These are the three classic findings in cases related to chronic chest infection. Here we have consolidation with air bronchogram in both upper lobes in association with the bronchiectasis due to old infection here. The current infection presented by consolidation, lobar consolidation in upper lobes, plus the predominance of bronchiectasis. We have mucus plugging. We have tree embed, mosaic attenuation is one of signs of small airway disease, plus of the presence of the tree embed. So in this situation, we have involvement of both large and small airway disease in chronic infection of specific etiology. The predominance in upper lobes is suggestive of either cystic fibrosis and allergic bronchopulmonary aspergillosis. The age and absence of history of bronchial asthma, absence of high mucus attenuation in mediastinal window is in favor of cystic fibrosis. Let's go to 23 scan. Here, patient shows another presentation of the infection. Widespread ground glass opacity. Here you can appreciate presence of crazy paving, interlobular septal thickening, bounding the areas of ground glasses. So we have crazy paving and ground glass opacities elsewhere, representing acute infection on top of bronchiectasis, tree embed, extensive tree embed, as you can see here, and mucus plugging, the triad of a specific etiology for chronic infection. But mucus plugging here is less than the scan in 21, and here are the examples of the mucus plugging. Let's revise again then 21, the mucus plugging. Here you can see more mucus plugging. Here as well in the left upper lobe. Here, left lower lobe, right lower lobe, tree embed, mucus plugging again. All these are mucus plugging. Bronchi, dilated bronchi filled with mucus. But I think you agree of the predominance of the findings in upper lobes. So, according to the flow chart I posted before in Twitter, and I have a series of video lectures talking about the differential diagnosis of diffuse bronchiectasis. When we reach that the diffuse bronchiectasis is not tractional bronchiectasis, not due to fibrosing lung disease. There is no characteristic tracheobronchomegaly or emphysema in lower lobes. So we will judge the predominance of the findings into upper lobar or lower lobar when it is central in distribution, as you notice here, even if it is peripheral bronchiectasis, diffuse bronchiectasis, no option for the upper lobar differential. So even if you cannot judge if the bronchiectasis diffuse, they are central or peripheral, presence of them upper lobar will limit the differential into cystic fibrosis and allergic bronchopulmonary aspergillosis. And high attenuation mucus is the only radiological differentiation between both. In our case, the case was proven clinically that it is cystic fibrosis, and but in radiology and in HRCT, it's better to mention the differential diagnosis. And according to the age, absence of bronchial asthma, you will mention cystic fibrosis, more likely, and less likely allergic bronchopulmonary aspergillosis, as a combination of both can happen in HRCT and in clinical practice. ABA can complicate cystic fibrosis, and both entities can be present in the same patient. Another way to assess this entity that the chronic infection due to specific etiology has this combination of triad, central bronchiectasis, mucus plugging, dream bud. If they are present upper lobar, the differential will be cystic fibrosis versus allergic bronchopulmonary aspergillosis as our case. Thanks for your attention.